It's my huge pleasure to be here today, and I want to congratulate the organizers because the way these sessions were organized for this morning's second part, they make all sense. You have been discussing diffuse gastric cancer in the sporadic setting, and what I will try to bring to you is also what the contributions are from the study of diffuse gastric cancer in the hereditary setting, and that may be helpful from a certain time point on, and we are learning more and more and more about that. Gastric cancer is really something I like very much. I've dedicated most of my life in research to this issue. And still from the previous talk, and you understood already, I'm a pathologist. I want to emphasize what Stefan has said, because he made a major statement: the pathologist is mandatory. Have you noticed? It was written there. No, I'm saying this because many of the problems you are facing is because you have shortage of pathologists. And if you have shortage of pathologists, this is by itself a problem. It's also a problem to get expertise for the discussion of the issues you have been analyzing this morning. Because when you come to a group of diffuse cancers and you understand that this is a bunch of crabs and you have to specify which subgroups are behind, you need expertise. So make a movement to support the pathologists, because we really need that. But now coming more seriously to what brought me today here, what I'm trying to do is to make an update, because we know a lot about gastric cancer and specifically hereditary gastric cancer. And just to begin with, all of us are aware that you can have cancer in the stomach in the setting of several hereditary syndromes, and you can have cancer in the stomach in the setting of Linkage syndrome. You can have cancer in the stomach in Liefraum and Port-Jäger's familial adenomatous polyposis. I went to highlight this one because we'll come back. In the past, we thought it would be just polyps, adenomatous, but things are changing. So please pay some attention to this. See here some special figures regarding stomach cancer statistics. And we know that gastric cancer is the 5th most common cancer worldwide, but it can pass everything. And among the gastric cancer world, only 1 to 3% correspond to hereditary gastric cancer. And there is more than one inherited syndrome of gastric cancer. And there is also, we know that what is the risk of the clinical presentation of the disease, and we'll go to that in detail. So when you think about familial hereditary gastric cancer, you should think about 3 main syndromes. The one I'm going to dedicate more time is hereditary diffuse gastric cancer, because it's very important for understanding what we have been done this morning before. But I will address also the gastric adenocarcinoma and proximal polyposis of the stomach. And also, I will not approach this one, familial intestinal gastric cancer, because we know this corresponds to cases in which in families you have several members, you have a pattern of dominant inheritance, but you have no idea what the genetic defect is behind. So this is still an issue that needs clarification and concerns gastric cancer of intestinal type. So you don't know to balance correctly what environmental factors against the susceptibility factors, encompassing also other genes that can be not so determinant for the development of the disease. But if you come to the hereditary diffuse gastric cancer, and we come always to New Zealand, we come to Maori kindred, we come to this huge family in which there are several generations, many patients dying of the disease at the age already of 14, and we come to Perry Guilford, who is the senior author of this paper published in Nature in 1998, was clever enough to come to something that was a very intelligent decision. All these people with the disease and dying from the disease, they had gastric cancer. He knew that gastric cancer is heterogeneous. So instead of jumping in the dark, fishing something that nobody knew by that time what could be, high-throughput technology was not that available, what he decided was to study the histology of the cases. And the histology was diffuse type. And by that time, in Germany, Becker had already identified ecadrine gene mutations, somatic mutations, as the cause of sporadic gastric cancer. So instead of being lost through histology They went to search for germline mutations of this gene, CDH1 encoding for ecadrin. So they searched for the carriers of the phenotype, and they identified, yes, a linkage between the phenotype and mutations in CDH1 gene. So they came to the definition of this syndrome, which is hereditary diffuse gastric cancer. There in New Zealand, they would require the demonstration of the mutation before qualifying a family with having this syndrome. And I'm very happy because next year, for the first time, we'll have a meeting of the International Gastric Cancer Linkage in New Zealand, which had not been possible before. It's very expensive. We'll see if we manage. So this became relevant and more relevant and led to the last edition of WHO book, published 2010, to one individual chapter on diffuse gastric cancer. Amanda Charlton was the pathologist who had studied the case for New Zealand, and she was very, very important for this chapter. We are now presently preparing the next edition of WHO classification. So what was discussed this morning is very relevant for that, because by the end of this year, you will have the new WHO classification, and I'm sure, because there are two people in this room, will be involved in that, in this classification, the issue of diffuse gastric cancer will be approached. And so this is very relevant, and I promise that by the end of this year, we'll have something that we hope will be more clear for clinical application. So regarding hereditary diffuse gastric cancer, you have to approach genetic susceptibility, the molecular pathology, the clinical features, and pathology itself. So from the genetic susceptibility, you know that the mutation affects the CDH1 gene, which is a long one with 16 exons, and does not spare any exon of the gene. So when you have a candidate family, you have to search for mutations along all the lengths of the gene. Most of the mutations here represent above the bar. They are truncating mutations and expected to be pathogenic, but still there is something like 20% of the mutations that are missense mutations. Some of them can be pathogenic, but they should be tested using several tools, including in vitro studies, to come to the conclusion before acting in a specific individual, in a specific family. So here is more or less a summary of what happened a long time since the syndrome was identified until 2015, and more recently are the news. So at the beginning, we knew that the mutation affects these families, and the percentage of families with the clinical symptoms in which mutations could be found was something like 25%. All over the world, everybody with families, candidate families, would search for the mutations, and this increased the percentage of families with CDH1 mutations, but still there were a high percentage of families without mutations, but with a clinical phenotype. And the search for the mutations led also to identification of something which is CDH1 deletions, and everybody should be aware because this is the cause of the genetic defect of the syndrome. So, but still, because there were many cases for which mutations or deletions were not identified, everybody began to search for alterations in the genes. So high-throughput technology was applied, and there is a list of candidate genes. So for those of you who are clinicians who would think in your routine practice, if you have a family with the clinical criteria and which is negative for CDH1 mutation, what am I going to do? And that's why I'm going a bit more in depth here. And what you should do is not to get lost. So please do not ask your geneticist to search for this unless you have NGS panel. But if you do not, please apply the search to specific genes which are those besides CDH1, those that can be candidates for the genetic cause. And this is CTNNA1, which encodes for alpha-catenin, and this is MAP3K6. All others have been identified in families, but the evidence is not enough to qualify them as genetic causes of hereditary diffuse gastric cancer. So after having described this, the screening all over the world was also in the search of these alterations, and it was found that in the whole group of hereditary diffuse gastric cancer families, about 6% of those would have mutations in genes other than CDH1, and we should be aware of that. And it means that this is a summary of what I said, and this was the consolidation of this gene encoding for alpha-catenin as one of the genes causing this syndrome in these families, and this is maybe the most important paper at the beginning, but others followed. So you have enough evidence in the literature, and the International Gastric Cancer Linkage Consortium will for sure include this as one of the recommendations. But we are now facing already the future and analyzing what else have been done, and that is there, because still we had this proportion of cases in which you do not know the genetic cause, and this is still encompassing for 53%. What I'm talking now is research, not translated yet, but should be known. And what is research comes from the group in Porto, from Carlos Oliveira mainly, and the situation is like this. The case in which you have CDH1 mutations or mutations in the other genes, they have the same morphological phenotype as the cases that are negative, at least at early stage. So in a way, indicating that CDH1 gene could still be the cause. And what Carla and their group have done is to search for the alterations in these genes, and what they have seen is that when you have CDH1 mutation, you have alteration of DNA, and at the RNA level, you have decreased expression of the corresponding allele. And what she identified in their group is that in case negative for the mutation, even without DNA alteration, there is loss of expression of one allele. So there is a percentage of cases in which there is allelic imbalance of the expression of CDH1 gene, and this corresponds to something that is something like 37% of the cases. This, if demonstrated, would decrease drastically the percentage of families for which there is no alteration at all in CDH1 gene or the related genes. So this part, this green part, is still research, but is something that those of you who may be interested also in testing and checking would be very nice. When you come to molecular pathology, and now I'm referring to what we have in our ments, our tissue we receive, we know this is a typical bona fide case in which you have the expression of ecadrine in the normal non-neoplastic epithelium, and here you see the neoplastic cells, signet ring cell phenotype, completely negative in this case. And as Stefan also explained so brilliant, what you have is the neoplastic cells below the surface, and at early stages they do not reach the surface of the mucosa, so the difficulties of identification have been discussed already. So we know that all these cells, they have a germline mutation, but the loss of expression of ecadrine occurs only in the neoplastic tissue, so it means there is an inactivation of the wild allele. There is a second hit that in this model of CDH1 as a genetic cause of hereditary gastric cancer, among the different putative causes of inactivation, the one that is the most common is promoter methylation. When this was identified, some people even thought that one possibility to treat the carriers without evidence of disease was to give some inhibition of methylation, but this proved not to be a successful idea. Why? Because we have studied, and this is also part of the work done by Carlos Oliveira, in specimens of gastrectomy in which you had the possibility of studying different foci in the mucosa itself and also in lymph nodes from the same stomach. We could demonstrate that there is a proportion of cases in which the most frequent lesion can exist only as promoter methylation. In other case, there is LOH. In other case, there is the two together. In other case, there is an additional mutation. And you can even have an additional mutation, promoter methylation, and LOH. So it's very complex, the mechanisms of inactivation of the wild allele in the stomach besides the germline mutation the patient in inherited. So these preventive measures with inhibitors of methylation will not work because this is more complex, this is more heterogeneous, and even in this setting, gastric cancer is heterogeneous. But now if you look at pathology, pure pathology, what we see at our microscopes, this model, most of the cases, we can see beautiful images. This is one case of intermucosal signet ring cell diffuse carcinoma. So this is one case of diffuse carcinoma, and please pay attention, most of the cases in the setting of hereditary diffuse gastric cancer, they are, at least in early phases, pure signet ring cell phenotype. This is a pure signet ring cell phenotype, fantastic, beautiful. You see the glands, you see here the signet ring cells, and it's beautiful at the microscope. This is what you can see in the early foci that you identify in a stomach that was removed as a prophylactic gastrectomy in a carrier of a pathogenic CDH1 mutation. You see nothing when you open the stomach. Biopsies before the gastrectomy could have been negative, but when you totally embed, you can see several foci in most of the cases. We have made a revision recently of the results when you have the full stomach that is completely normal, and you apply a research protocol for the identification of a different foci. If you follow that protocol in the setting of hereditary diffuse gastric cancer, in CDH1 carriers, the percentage of cases in which you find hidden foci is something like 95%. But you have to apply a protocol. And that's a lot of work, and many pathology departments cannot afford to apply because this means expertise, a lot of work. So what you have? Reference centers, while the pathologists, they survive, because this is really a lot of work. So what can you else find in those stomachs beside different foci of intermucosal signet ring cell carcinoma? You can see the precursor lesions, the beautiful plastoid spread of signet ring cells, and in situ carcinoma, something that is not frequently found, something that even I doubted that existed until the day she had one case with several of these lesions, because it's rare to find them. It means that you can have intermucosal invasive lesions that develop without the precursors, and most probably they come from the neck zone, as Stefan has already explained. So, but the problem is in everyday life. In everyday life, you have patients, you have carriers, and you submit the carriers to endoscopy, and you take biopsies, and you have to come up to a decision on what the diagnosis is on the biopsies. So more and more you receive biopsies in consultation, and this is one of the cases that I received recently that was sent to me with the suggestions of being something reactive and with some vascular alterations in the stomach, in the chorion, on the lamina propria. But actually, for those of you who are already trained in looking at pathology, this is a normal gland, and this is in situ carcinoma. You can see the signet ring cells still confined to a basement membrane, so you really need expertise. You need eye power to look at the lesions, and you need the time to search for them. And here, what has been interpreted as being capillaries, these are signet ring cells. So in this biopsy, sent in consultation very wisely, for which the diagnosis initial was negative for signet ring cell cancer, not only displayed in situ lesion, but also the evidence of intermucosal invasion. So it means that really consultation is something that is mandatory. Do we pathologists can use additional things, such as searching for ecadrin expression in the neoplastic cells? That could be useful in our everyday diagnosis, not only for confirming the diagnosis, but also for suggesting if it is hereditary or sporadic. And unfortunately, the answer is no, because in the hereditary setting, you can see a range from complete absence of ecadrin expression, just decrease the expression, or you can have this dot pattern, or even cytoplasmic expression in missense mutations. So you cannot extract from immunohistochemistry any help. But we know for immunohistochemistry that the loss of expression of ecadrine occurs very early in the development of hereditary diffuse gastric cancer, because you can see that already at the phase of those in situ lesions that I've been describing. And you jump now to something that refers to the clinical features. Why this? What I'm showing you is a meeting of the International Gastric Cancer Linkage Consortium. I select this one because this one was in Porto, and this is our institute, and here you can see several people. You can see here, where are you? Here, there he is, Roviello. Franco Roviello is a member of this group. Carlos Caldas has been for long the leader of this group. Rebecca Fitzgerald, is she in the room? Because now she is the person in charge of this group, and she's there. You have listened to her. And you have Perry Guilford, and you have Henry Lynch. And these people have been moving along. The last time we met was in the Netherlands, and the last guidelines, and Rebecca is the senior author of those, come up from 2015. So this group at the beginning, and this was one of the important things that was decided, is to offer to the carriers of pathogenic mutations. It was to offer to these carriers, and most of these pathogenic mutations, they are truncatic mutations. As I said, some of the missense can also be pathogenic, to offer them the possibility of being submitted to prophylactic hysterectomy, now more frequently described as risk-reducing hysterectomy, or the possibility of being submitted to intensive screening. I don't know if Rebecca has commented already yesterday, but her group has a lot of experience using the Cambridge protocol, increasing a lot the yield of endoscopy in detecting early lesions preoperatively. So we can come back to the discussion of this because this is relevant. For us, pathologists, what is led was the opportunity to study prophylactic hysterectomies extensively and to come up to a pattern which is, as I said before, even if it is negative, if the patient has no symptoms, the endoscopy is negative, the biopsies are negative, if he is a carrier at a certain time point, they come up to prophylactic hysterectomy, and those who've studied according to a research protocol, they are very informative regarding what we can see there. You should be aware that the disease, being a carrier of the genetic defect, does not mean you will have the clinical phenotype. The penetrance has been reported to be 70% for men and 56% for women at the age of 8 years. This is the paper I was quoting already, the last guidelines, 2015, for which Rebecca is the senior author. And this is the summary of the guidelines. This is a figure that it is in the paper. We will not discuss these guidelines in detail, but they are to be read by those who have cases in which this has to be considered. What is very clear is the criteria that were clearly established to refer an individual for genetic testing, and these are very clear. And besides those that are very clear, they are clinical criteria, there is also here something like considering the possibility of some lesions identified by pathologists being enough to refer a case for genetic testing. And these are the precursor lesions such as parasitoid spread. So the genetic testing, there is an age for after informed consent, and should include MPLA because of the deletions I mentioned before. And if this is not done, in a negative case, you cannot exclude ecadrine or CDH1 as one of the causes. What is real critical here is always the multidisciplinarity of the approach, even pre-endoscopic and surgical interventions or after the risk-reducing hysterectomy. So this is very important. And now I come to something that is really relevant for the discussion we had before. Someone asked, in a biopsy, can you distinguish between signet ring cell? Can you distinguish this from poorly acquisitive, not otherwise specified? Because both, they are diffuse type. And the answer is yes. What I'm showing you in this biopsy is one family with the same CDH1 mutation and different morphology. So heterogeneity attacks also the morphology of hereditary diffuse gastric cancer. This is the morphology of one biopsy in a patient 18 years who died of the disease in 2 months. And if you look at this, in this setting, what you should report is poorly cohesive carcinoma, not otherwise specified. All the fragments we received in biopsy from this patient had this morphology, although there are few signet ring cells in other samples, but this was the most predominant. So yes, you can see this in a biopsy. And this is the biopsy of the sister of this individual at the age of 14 years because there was a panic in the family. This died at the age of 18, so the family really asked for this girl who was a carrier to be submitted to prophylactic gastrectomy, much younger than the age of consent. So this was brought to the ethical committee that approved the request of the family and the patient, and she was submitted to prophylactic gastrectomy, and she had at the age already 14 distinct foci of cancer, and in her case, bona fide signet ring cell type. So yes, what we think, what does this show? This shows that the lesions are there from early stage. We don't know how early. You don't know what bursts and makes it all of a sudden to expand and become aggressive. And we have performed a couple of studies trying to address this issue. And we think these days that there is an indolent phenotype in hereditary diffuse gastric cancer. And the phenotype is early invasive tumors with signet ring cells, with low proliferative index, without p53 expression. But this can progress to an aggressive phenotype in gastric cancer, in which you have diffuse carcinoma, non-cohesive, pure non-cohesive cells, poor cohesive carcinoma subtype, in which you have proliferative index which is high, and we have the expression of p53. The problem is we don't know when this happens. What we suggest is that if in a biopsy we see this phenotype, we should add a note that this can be a criterion to, in a way, an indication for an early gastrectomy. And we come very briefly now to the other gastric carcinoma, which is the so-called GAPS, which is gastric adenocarcinoma and proximal polyposis of the stomach. You know the phenotype, those of you who are interested in this type of cancer. There is a profuse polyposis in the proximal stomach. Most of the polyps, they are fundic-gland polyps. They are polyps of other type. The interesting issue here is that there is dysplasia occurring at early age. This was one patient, 9 years, now not from New Zealand, but from Australia. And in some patients, there is invasive cancer. So this is the phenotype of the disease, and the clinical criteria for the diagnosis of GAPS have been established and are published. One thing everybody should be aware is that this diagnosis should consider only in patients we are out of the use of PPIs, because PPIs by themselves, they lead to the appearance of fundic-gland polyps, and is part of the work out of these patients to look what's happening in the colon, because these polyps they occur in the stomach without evidence of colorectal or duodenal polyposis. This is very relevant what I'm saying now because of the final classification of this syndrome. This syndrome was described first time in 2012, and it was described in Australia in a group encompassing people from other areas, and also in Japan. The two groups in parallel, they have searched for mutations in the same genes, including APC that was negative, MUT-YH that was negative. So the genetic cause was not known, and took at least 4 years to come up to the identification of the genetic defect of this gene. And the genetic defect of GAPS is now known that it is the occurrence of point mutations in exon 1B of APC gene. And so this led to the current classification of GAPS as a variant of FAP. So now it's considered as a variant. How can we make a comprehensive interpretation of all this? We have now the gene we have APC gene, you have the exons, and you have the hotspots for the mutations. In exon 15 is where most of the mutations occur in classical severe FAP. You know that at the extremities you can have mutations that are behind attenuate FAP, in which you have lesions in the colon and the stomach. So the target organ is mainly the colon. In the attenuated, the target organs can be the colon and the stomach. And if you have mutations in APC gene, in the promoter gene, you have the GAPS syndrome, and here the stomach is the single target. So it becomes a bit strange that we have a fundic gland polyposis affecting the stomach and not the colon and rectum, but is considered, because of the localization of the mutation, is considered as a variant of FAP. And are there other cases described in the world? We have in our hands currently one Portuguese case, which is a serious candidate, and there is this family from Czech Republic. There is another published from Hungary also. So we come to the end of this talk, just highlighting that we are at the age of integrated molecular pathology, because we are now able to put molecular pathology with all heterogeneity that is spatial, temporal, together with information from genomics, epigenomics, proteogenomics. And from this, what all of us should be tempted to do is to correlate with the clinical phenotype, and altogether this will lead to better understanding, and translation to clinics is the most relevant of this story. So what we need is bridges. That is something we have a lot in Port. Some of you know that very well. This is a Rabbit bridge over the Douro River, and thanks so much for your attention.